Hello everyone, this is Karen O'Hara, Director of Marketing and Communications with WorkCare. Thank you for joining us for week 27 of our briefing on preventing and managing COVID-19 in the workplace. Many of you join us every week. We really appreciate your participation. And if you're just joining us for the first time, welcome. I just wanted to mention, and Alexis has already posted on the chat, that we're going to be doing a special event on Thursday, September 24th on flu season preparedness. The title of the webinar is Workplace Interventions to Tackle Flu Season During the COVID-19 Pandemic. As you all know, this is a really unique situation, and extra steps need to be taken for interventions to prevent the flu from becoming a problem in conjunction with COVID. So I hope you can join us for that, and if not, it will be recorded and we'll be publishing the recording. There's no cost for this webinar. For today's session, you're on mute. Please submit your questions using the Q&A function in Zoom. The webinar lasts about 40 minutes. Dr. Harris will take questions at the conclusion of the webinar, and any questions we don't have time to answer, we'll answer in writing in our weekly post, which is on our website. Dr. Harris is an MD, MBA, MPH. He's our Chief Innovation Officer and Associate Medical Director for On-Site Clinical Operations. He's also our lead clinician for our COVID-19 response. Dr. Harris is board certified in occupational medicine. I'll turn it over to him. Thanks again for joining us.
Excellent. Thank you, Karen, and thanks everyone for joining us again here. Happy to be talking to you today about the long-term picture of what we're dealing with this COVID pandemic and helping understand what are some of the things we need to be thinking about and be considering as we approach the end of this year, beginning of next year, and onward. And so to elucidate that fully, we're going to dig into some of the particulars about this pandemic and the particulars about the epidemiology of coronaviruses in general, and then specifically with COVID-19. And we're going to talk about some of the pathology. So we're going to put on both our epidemiology hat today, and then we're going to jump over and put on our business hat and think about what are the implications for the company and your workforce, and what are some of the things you need to be considering as an EHS professional to ensure that moving forward, your strategy is going to be appropriate for what we anticipate COVID-19 how COVID-19 will end up. So without further ado, we'll jump into the format that you should be familiar with if you're joining us for the second, third, or 27th time. Clinical update first, followed by microbiology and pathology. We'll jump into the epidemiology, zooming in on the US, then extracting back to the macro of the global impact of COVID. And we'll talk about the prevention and specific workforce strategies we recommend from WorkCare in terms of your consideration. And so today, when we talk about clinical presentation, we're going to zero in on the presentation clinically of different epidemiology, different epidemic rather, seasonal flu, viruses, bacteria even, and the impact that we believe historically will play out with COVID-19. And we know that there are a number of illnesses that are seasonal, appear to be seasonal related, but exactly how many are in fact related to seasonality or have an impact from a seasonality standpoint. If we turn to a publication back in November of 2018 from Columbia University in New York, Dr. Martinez is a researcher with the School of Public Health. And in her publication, which has been cited numerous times, she identifies 68 different illnesses that have seasonality to them. Amongst them, some you will be familiar with: chickenpox, for example, cholera, diphtheria, the D part of Tdap immunizations, and others like E. coli even have a seasonality to them that has been studied and associated. And so if we look at other articles that have cited this work and depict it in a different way, we can see amongst some of the well-known illnesses, the seasonality depicted here. For example, smallpox peaking in the late spring in May. Even hepatitis, a chronic illness, has some seasonality to it, peaking in the late summer. If we look at flu, influenza, we know it peaks in the late winter, beginning of the spring, right? And so again, there is definitive seasonality to a number of illnesses that we have studied over the years, and we are now looking to COVID-19 to identify whether or not it's going to have seasonality, and that's going to help predict how we respond, right, to the illness. Now, to get to this level of, so taking this data and then trying to create a predictive model for COVID-19, it all begins with looking at some basics. And so again, put on your geek out hat right now, because we're going to jump into some not too complicated, but relatively more complicated than what we typically talk about in this webinar. Nonetheless, this is a model. It's called the SIR model schematic. Stands for susceptible, infected, and recovered individuals for a particular illness, right? And it can get pretty complicated, but again, our goal is to simplify this so that everyone is on the same page as to how we can begin to understand the impact from COVID-19 as it relates to its infectiousness and how it affects the population over time. So we'll identify this model in a different way, all right? And so if we think about the S being the number of people that are susceptible in a population, well, let's just take the US, for example, then we will look at those who are susceptible and those who end up becoming infected and represent the infected individuals with an I, okay? And then finally, those people who recover or are removed from the population that can be affected or susceptible is represented by an R. Now, there's two ways to fall into that R category. Either you've recovered or unfortunately you've succumbed and died from the illness, all right? And so we wanna identify this model, and we wanna then look at two more variables in regards to this model that's gonna help us understand COVID and how it may play out here. Specifically, the additional two variables we want to look at in this model, again, looking at the population of susceptible S, the infected I, and the recovered R. B, or beta in this case, is the transition from susceptible to infected, right? The rate of infectiousness of this particular illness that we're talking about or trying to identify. And then we have gamma. Gamma is the transition from I'm infected and I've recovered. So it's basically the recovery rate, okay? And as we look at these two variables, we want to hold them in our memory so that as we understand and start to look at the specifics to COVID, as opposed to other illnesses, we can understand more deeply, again, how this might all play out. And so just put another way, depicted here, transmission rate is that beta we're going to consider, and recovery rate is that gamma we're going to consider between these different categories of this model. Now, there are other models that articulate illness, transmission, and recovery. This is only one that is widely used by epidemiologists to understand the effects and transmission of an illness in the population, okay? And so if we look at the curves that's represented typically by this particular model, okay, we have variables here that will explain. The S is the susceptible, okay, recall that. S sub T just means over time, what happens to the number of susceptible individuals, it generally decreases, right? So given at the beginning of a epidemic or pandemic that everybody particularly could be susceptible, that number should decrease over time as individuals become infected, all right? So now let's look at the I in this model. The I curve increases over time because the number of people becoming infected increases in general, right? And it reaches a nidus, or it reaches a crest, if you would, the peak of infection. And that's represented by the top of that red curve you see there, and then decreases again over time because individuals are recovering from the illness. And so if we identify now the R curve, that is the individuals who are recovering over time from a particular illness, R sub T. Now, you'll recall that we've described this variable in other ways, R naught, which is the base infectiousness of a particular, or recovery of a particular illness. And we'll talk more about that here shortly. But just hold this model again in your memory as we go forward here. So that's what we want to bring up here in regard to the clinical presentation, seasonality, and how we identify different illnesses thereof from an epidemiology standpoint. So now let's zoom in to a model that's specific to COVID-19. And this particular study was conducted and published this year, first published in June, and then an update was published just recently here in October, just recently here as well. And so what we want to identify in this particular publication is looking at their curves. And in their curves that they published from historic data from the US, they looked at how the illness progressed from January all the way through June, okay? And then they modeled out what would happen in August and moving forward, okay? And when we talk about looking at the different pieces of their curve, they have represented here I, the total number of infections, so it's I sub T. Then they looked at the rate of infection, okay, in terms of days elapsed since the beginning of the pandemic. They also looked at then the rate of recovery, and we won't identify, we're not going to go into too much detail here, but I want you to understand the general principles here around this data. And then they also looked at the deaths. Again, that's how people can also be removed from this susceptible population. And then they articulated the actual susceptible population for the US, again, over time, days elapsed. And as you can see there's not a smooth curve, right, on that S curve. If you recall the previous model that we looked at, susceptibility decreased over time in general. Here it decreases, and then you have these spikes in the curve, and that's representative of new populations becoming susceptible, okay? The study, these type of models in general can assume two things. One, homogeneity, meaning of the infected and susceptible individuals, meaning that if you are susceptible or infected, you're kind of generally mixed in the population at an even keel number, okay? But what we see is with these spikes here in the susceptible population is secondary to people traveling from one location to another and actually causing new levels of susceptibility in different populations, okay? So that's representative of these spikes here. And as we move forward, when we look and drill down to the actual numbers here that they looked at historically and that they eventually predicted, we're seeing recoveries, if we're looking at percentage here, well, let's identify active first. So the active individuals who are infected from the historic was about 54%. Recovery was 39%, and deaths were 5.5%, okay? And then if we looked at what they tried to predict out, it was 24%, about half of the active, as the historic data showed. Recovery was 70, and deaths were 5.7, all right? And so the trend is what we want to identify here in terms of that model and that prediction, because the trend is what changes if COVID plays out differently from the classic susceptibility model that we're presented here, where if an individual gets infected, they recover as we're looking at here, and they're no longer in that susceptibility range. The important thing to hold here as well, in terms of concept, is the best way to minimize the length of a epidemic or pandemic is to decrease the number of active infections, okay? And so we want to make sure that we understand the peak infection is going to cause, the higher the peak infection, that's going to cause a lengthening of our experience with a particular pandemic. And that's what we're seeing here in these two different curves modeled out here. Much lower peak in the second graph below leads to a decrease in the number of total infections over time, as well as the decrease in the rate, okay? So we wanna pay attention to that as we move forward. Again, the important number that we wanna identify is that RT, okay? That rate of transmission and rate of recovery here. And let's drill down now, more granular, into each state. What are the states experiencing? We presented some data on this in the past. We want to update and identify now in this particular study that was published, looking at statistics from all states in the U.S. As of September 14th. How are they faring with that R naught or R sub T in terms of rate of infectiousness? Okay, if we look at then the hardest hit states, we're seeing numbers above 1. So what does that mean? Okay, an R below, an R value, R sub T below 1 means that not fully an individual is infecting one-to-one once they contract COVID someone else. Okay, but if that number is above 1 or obviously greater than 1, then we want to pay attention, because that means an individual once infected is going to infect on average one other person at least. Okay, and so this is a little different. This is the actual rate, right? So this is a little different than what we identified as R sub naught, kind of the base infectiousness of a particular illness. Previously, we identified that as 2.5 for SARS-CoV-2, all right? This is an individual state by state per population rate, okay? That's the main difference here, that these numbers are averaged out over these particular states and their given population. So it's a relative number, but an important number nonetheless to help us understand the impact and long-term longevity of COVID-19. So when we look at this number in a different study here published looking at the US data, also looked at China and Italy, but we'll focus and zoom in here on the US in particular. We see down here, let me grab I think I have a laser pointer here. Let's see if we can grab that. So the numbers we're looking at RT here range, right? Average out from about 1.5 all the way up to 2 across the board, looking at multiple states, okay? And so again, we want to pay attention to that RT value as we move forward, because it impacts again, the longevity, potential longevity of SARS-CoV-2. So let's look at now, we've examined now, right, what happens with a particular outbreak, pandemic, epidemic, and the associated model if people recover and have longevity in their recovery of that particular illness, right? And so let's ask the question, is that likely to be the case for SARS-CoV-2? 2 weeks ago, we talked about and presented data from a case in Hong Kong of reinfection after about 124 days, right? Genetically demonstrated to be 2 different strains of SARS-CoV-2. And so we want to ask the question, is that going to be the trend for COVID-19? That the recovery from an infection and immunity is transient. And if we look at, in this particular study, the attempt to identify that, we can see in this study that examined individuals over a 35-year period and their level of infection and reinfection from common coronaviruses. We can see that they have actually contracted these common coronaviruses, which are an NL63, 22.9E, OC43, and HKU1. These are the coronaviruses that are in the common general population. These individuals had a total of reinfection in some cases of 11, 12, right? Some only 3 times. But again, they've been infected multiple times from a coronavirus that's common in the population. Okay, and so this gives us some and gives some credence from a scientific and evidence-based approach that coronavirus, SARS-CoV-2, may play out in this similar fashion in terms of reinfectiousness. Obviously, seeing some of that early data coming from Hong Kong. So instead of that nice curve that decreases over time in terms of susceptibility and incidence over time, and being at a low level, we're likely to see, if this plays out in this reinfectious environment, some steady state, right? Oscillations of infectiousness over time in terms of years, and as some type of steady state where we're seeing people move in and out of that population of it in susceptibility. And these curves represent that, right? That the daily incidence in population per million over years will likely mirror, if we're looking at, again, that SIR model, something like this, right? Where we'll have occasional peaks of the virus over time. And again, this is all geared towards, and so this model is from flu. This is what we experience with the flu virus currently. And so again, if coronavirus plays out like it does from a seasonal standpoint, as well as reinfectiousness, then we need to be prepared for that. So when we talk about the epidemiology and looking at the numbers from a global and specific US perspective, what does it look like? Do we have any updates to that regard? And we can glean some of these trends from the data that we present on a weekly basis here. If we look at globally at if we look at the US at a high level, number of total cases, we went from 2 weeks ago, 6 million, to last week, 6.2, almost 6.3 million, and this week, 6.5, almost 6.6 million. Okay, and that's total number of cases. But if we look at in the last 7 days, the number of cases, 261,000, where did that number come from, right? What states contributed most to those numbers? We can see that here in the darkly colored states here, that most of those cases overwhelmingly came from the hardest hit states: California, Texas, Georgia, Florida, Illinois, right? So we want to pay attention to those hotspots. Obviously, that's germane to travel for your workforce. And we want to also look at now breaking down more granularly the number of cases per 100,000, okay? And if we look at these numbers from that perspective, we're seeing mostly those southeastern states that are representing the highest burden from a 100,000 population standpoint, all right? And these are cases per 100,000. And so if we back out to the global perspective, we showed 2 weeks ago where the US was. We were trending down and kind of flattened out a little bit in terms of total number of cases on a 7-day rolling average. We started to trend down slightly on that 7-day rolling average, but we did question whether or not that downward trend was associated with a decrease in testing. And we'll revisit that here shortly. But if we look at today where we stand, total number of cases, we've increased in terms of the rate, okay? And so we'll pay attention again week over week, the rate of increase and or decrease, but right now we're seeing a little bump here. And if we look at the number of deaths, we're seeing the same trend. 2 weeks ago where we were, last week trended down a bit, this week trending back up, okay? And so this is important, right, to how we maintain social distancing and safe practices and our ability to fully open up the economy and et cetera. And part of that narrative is looking at the data on testing, right? We've been examining the positive tests per, basically the number of tests percentage-wise that come back positive as we're testing in the US. We want this number to be decreasing. 2 weeks ago, this is where we were. Last week, the US down here, I'll grab my laser pointer again, US down here, started to increase slightly, again, heading in the wrong direction in that case. And this week, definitively, heading in the wrong direction, increasing the number or percentage of positive tests that are being conducted in the US. Not a good sign, right? If we look at then the total number of tests that are conducted in the US, we were 2 weeks ago looking at this downward trend here slightly. Again, this correlating to the CDC new recommendations around asymptomatic testing and not recommending it. We flattened out last week a bit here, but this week definitively we've dropped almost by 200,000 tests on a 7-day rolling average, okay? And so if there was any question as to the impact of the change from a CDC standpoint and in regards to how much testing is occurring in the US, we're down. And so that will have ramifications and impact in terms of the number of transmissions that occur. Because again, in countries that are doing well and are seeing decrease in transmission, surveillance is key, testing is key as to the performance of their experience with COVID-19. So now let's talk about prevention. We're getting more into prognosticating again into the future of what COVID-19 is going to look like. We looked at models that and understand how models are built to try to predict that seasonality and to the recovery, et cetera, of those who are susceptible and have recovered from an infection. And so when we look at articles that try to point to the future and experience with COVID-19, this Nature Journal article gives us some both realistic approaches and some hope for a positive future, and a little bit of a grim picture in different scenarios they paint out, right? But if we zoom into this article, we can see that like two things are prominent amongst researchers and clinicians, right? And two things are pointed out in terms of what we agree upon. That one, COVID-19 is here to stay. And the future depends on a lot of unknowns that we're continuing to uncover. And two, we're trying to understand the seasonality, but it really is going to be incumbent on what and how governments respond, as well as individuals during the remainder of this pandemic. If we look further in the article, we start to understand that and see prognostication around immunity, right? So if immunity lasts less than a year, for example, then the coronavirus can surge again until probably 2025, okay? And we'll be dealing with this in a episodic surge pattern, as we presented here moments ago with that flu virus graph on a continual basis. Now, we can also glean some hope from evidence that shows that personal behavior, such as hand washing, wearing masks, have been really effective. And if we look at data from the College of London that looked at 53 countries that have begun to reopen, the surge has not been observed. And they liken that to the models that were predicted if a surge would come after reopening, undervalued the behavioral modifications that the population was able to engender, okay? And so obviously that's meaningful in our approach to help prevent transmission in the workplace, realizing that personal, individual behavioral modification can be very beneficial in terms of preventing infection. If we look at then again, putting our MBA hat on, the impact to the workforce and trying to understand what is the workforce going to look like in the future, this article gives us some glimpses of that as well in terms of surveying over 1,200 employees, and their response to this survey gives us an inkling as to the level of productivity actually during this pandemic. And if we pull out some and focus on some of the data from this publication, we can see that individuals who work remotely actually have done better with regard to their productivity performance than individuals who may have either stayed on site or remained remote and always been remote, okay? Now, it's not a head-to-head comparison in this particular publication, but it gives us an indication that those who transitioned to a remote working scenario, the majority of them reported that on individual tasks, they believed and felt and saw a productivity gain compared to when they were on site, okay? If we look at those managerial tasks, same trend there. The majority of people, 60 versus 40, reported gains in productivity during COVID-19 versus prior to COVID-19. The area where this productivity increase was not seen was amongst collaborative tasks. So those who transitioned to remote saw a decrease in productivity to the tune of 44%, reporting 56% reporting a decrease in productivity that moved to remote setting for collaborative tasks. Okay, so that gives us some indication around, are remote workers going to be permanent? And other data, I won't present it here, is indicating yes, that up to sometimes 40% of the workforce in different industries may be permanently remote because of these both productivity gains as well as decrease in overhead costs in certain scenarios. Obviously, that's going to be impactful for us as EHS professionals and how we care for those workers that are going to be likely permanent in their remote status. So if we look at additional data that is trying to articulate what the future may look like, again, for COVID-19 and the oscillations of outbreaks, this study that we presented is a continuance of a study we presented here already. We can zoom into these different scenarios. So if immunity lasts for 40 weeks or less, right, we're going to see likely these winter outbreaks, much like the flu seasonality. Okay, and that's modeling this out since March 2020. If immunity lasts for 100 weeks, we'll see less of these outbreaks to a lesser extent of severity as well. Okay, and again, this is looking at per 100,000 individuals, or per million, individuals. If we look at then the transmission seasonality of these winter outbreaks, if transmission is in fact seasonal in nature, we'll see these episodic spikes again with a less frequent regularity than if individuals have this less than 40-week immunity. And then finally, if we see more long-term immune responses because of cross-immunity from other coronaviruses, which there may be some credence to, then we're going to see, hopefully, the decrease in the COVID-19 infections over time, with kind of these latent spikes far out into 2024 and a little bit into 2025, okay? So these are scenarios that may play out, and these are the patterns that we're going to be looking for as time progresses here, so that we can more accurately prognosticate on what and how we're experiencing COVID-19 moving forward, all right? And so what's the impact as we wrap up here with the over the half-hour mark? We want to talk about then what are the things that are going to be important for us to keep in the front part of our processes moving forward as EHS professionals, right? So we got to prepare for that permanent remote workforce. All right, we got to understand a couple of things and prepare a couple of things for them as we move forward. And that is one, absentee management, right? We got to understand that there will be most likely a redefining of mandatory time off from an illness versus PTO and sick days, right? If someone is ill, now working remotely in a permanent fashion, what days do they need to take required time off from a work comp standpoint? Because they don't have to leave the office anymore, right? They can continue, if they can continue to work from home in that sick status, is it a mandatory that they take the time off, or is it going to be voluntary in terms of taking time off? And drawing the line between the two is going to be critical to managing the workforce from a illness absentee standpoint, right? So we need to begin to think about that and put strategies in place. If we talk about then home ergonomics, we're seeing this already be impactful over the months that people have been increasingly working remotely. But how do we deal with and standardize our approach to home ergonomics? How do we individualize our approach to home ergonomics for those who may be vulnerable to musculoskeletal disorders as a result of working from home, right? And even doing these assessments is going to be different for different populations, and we have to be cognizant of approaches that are going to be appropriate for dealing with it. And then mental health and wellness is going to be ever more increasingly important for our workforce that don't have the advantage of engaging with other individuals in the workplace, right? And we're already seeing an uptick in depression, an uptick in anxiety, and these we know are being becoming more prevalent as a result of the isolation, if you would, of being remote workforce. And so how do we screen individuals for these so we can maintain a state of mental health wellness? How do we triage these individuals? How do we get them engaged in, if we have the resources, how do we get them engaged in those resources for dealing with mental health, right? And so when we talk about on-site prevention, what does that look like with this new permanency potentially to COVID-19? We're talking about now making permanent infrastructure changes, right? Looking at the engineering controls from an EHS standpoint, permanent barriers, permanent changes to HVAC, if you haven't done that yet, and looking at other means to engineer out hazard of transmission in the workplace. Access to hygiene and availability of hygiene in the different work environments will need to increase on a permanent basis. So how do we pull that off from a resource standpoint? Long-term PPE supplies, is that going to be necessary, right? How do we then determine who needs those permanent supplies in the workforce based upon their potential transmission risk, exposure and risk long term, right? And how and what criteria are used to determine those? Is it proximity? Is it potential nature of the job? Is it even something as simple as, hey, it's noisy in our environment, so we gotta yell, and that produces droplets, which increases transmission rate, et cetera, et cetera. So having in place that risk stratification for permanent access to these type of preventative strategies is going to be important. And then finally, well, not finally, but last on the list here we want to present is just administrative controls, right? What are the administrative controls that will be likely permanent, and how is that going to affect the workforce in general, right? If you have more workers that are coming in the evenings because we want to break up the daytime shifts, we know that shift work increases anxiety, increases depression, may impact productivity. So how do we put in place preventative strategies to help deal with the impact of those permanent shift changes to help minimize exposure and transmission at work? And so these considerations are important for on-site, but in the medium term, right, not short term, but let's put it as medium term, as we deal with COVID, as we deal with flu, what are the considerations we need to hold prominent here? Testing. COVID testing is still going to be important. If we look at populations of large general population in the U.S. that are doing well, let's say universities and students. There are universities that are back in school that are in person, and their infection rates are low. What are they doing right? They're testing, and they're testing frequently. In some cases, once a week, every student. In some cases, twice a week. And speaking to a university in North Carolina, they're testing a certain population of students on a daily basis. And their infection rates in some cases are zero transmissions in some populations and very little in others. So we know that that strategy can work in large groups of individuals that have in-person contact on a routine basis. Vaccinations, obviously planning for the flu, planning for an eventual COVID vaccine. On-site in particular is going to be important. If you haven't started working on that plan, we'll work with you to help get that in place. And then finally, increasing collaboration and productivity in general for those remote workers and collaborating with on-site workers is going to be important from an overall standpoint of keeping the workforce healthy and productive. So with that, we'll go ahead and hit the pause button. We'll start and open up the questions because I'm sure we're going to get a lot of them because we've covered a lot in this particular presentation. So thank you so much.
Thanks, Dr. Harris. Yes, we did get a lot of questions related to your geeking out that are so complicated. We'll probably have to save them to address them in writing. So those of you who asked a complex question where you cite other sources, we'll address those in writing. There's one really quickly we can answer, and that is whether you can get COVID and the flu at the same time, and the answer to that is yes. One person wants to know what the SIR model for flu looks like.
Sure. So the SI model for flu is more, let me grab it here, because that's the graph that we presented here. So this is the daily incidence based upon an SI model for flu, the flu outbreak, okay? And so it's a constant transmission rate. You never see it going down asymptotically, if you would, towards a nidus. So we wanna you look at this as an example of what COVID or how COVID may present.
Okay, and generally speaking, there's one person who's asking a lot about the validity of case rates as opposed to mortality rates in comparison to hospitalizations and the veracity of different data. The comment is, I wish we would quit focusing on case numbers as there are many flaws in reporting. We're seeing a lot of false positives from PCR testing. Doesn't it seem like the death rate or the fatality rate is what we should be focusing on?
You know, that's a good question, but it's important to pay attention to, all the numbers, right? Because we have even, if we look at death rate only, right, we've heard criticism and seen flaws in reporting of death rate, where hospitals were overinflating the numbers of deaths attributed to COVID-19 because they were just, physicians were told just to list COVID-19 as the cause of death, right? So there are critiques and criticisms of the numbers on every front. And that's why it's important and incumbent on us to go to the, one, source of the data, and two, look at the rigor of the analysis of the data to understand how relevant it should be for us in our consideration on a day-to-day basis. But from our perspective, it's important to have a holistic picture versus narrowing in on only one or two variables as it pertains to understanding the impact from COVID-19.
Thank you. And we have time for one more question. And again, everyone, we do post the recording of this session on our YouTube channel, and we post the answers to all questions on our website. So be sure to check that out. The last question is related to OSHA's classification of COVID-19 positive cases as a recordable illness. Have you heard of any changes in their policy regarding that? I have not heard that they've made any changes.
No, I have not heard any updates yet from OSHA as to whether or not they are updating or changing their stance. Obviously states are taking an initiative to mandate from a state OSHA standpoint, a state regulatory standpoint, mandates for prevention. But in terms of work-relatedness, we know that a number of states have tried and failed to make the work-relatedness a default assumption, right, in terms of it being compensable. So we'll continue to pay attention to that and maybe even update during this presentation in a week or two to come.
Sounds like a good plan. Well, we're out of time. Unfortunately, the time flies by, but thank you all for joining us. We look forward to having back with us next week, same time, same place, and hope you can join us on Thursday the 24th for the flu session with Dr. Christopher Jankowski. Thank you, Dr. Harris, and thank you all for joining us. Be safe.
Thank you. Thank you, and everyone stay safe.